Hello, everyone. I am Ralph White III. I am one of the co-directors of cancer awareness when it comes to Black and cancer. Thank you so much for everyone being here. It's such a delight to see everyone wanting to get information when it comes to prostate cancer. And we have a lovely panel for you today. In terms of how this is going to go, we have a couple of questions for our panelists, and we'll also be accepting questions throughout. But before we get into that, drop in the chat, where is everyone coming from? We love to see where everyone is tuning in from, whether it's from the UK, whether it's beyond the UK, and even in the US. But it's such a blessing to see everyone here. Today is the prostate cancer expert panel. What we have going for us in this whole entire week, if you're just now joining us, is the FDA's initiative called the National Black Family Cancer Awareness Week. So we've already done breast cancer panel. We've already done understanding how we can craft a healthy diet. And so we wanted to bring it back more so when it comes to understanding prostate cancer. And so my colleague, Tani Mola-Martins, who's the other co-director, and I have selected 3 people to come and join us for this conversation on prostate cancer. And I will actually share with those people who you are now. First things first. One moment. Let me share my screen. So first things first, we have Professor Frank Chinegwundoh. Professor Frank Chinegwundoh is a consultant urological surgeon at Barts Health National Health Service Trust in London, UK, ever since 1996. And he's an honorary visiting professor in the School of Health Sciences in the City University of London. He's an academic clinician. He has a particular interest when it comes to ethnicity and prostate cancer. And he published his first paper when it comes to the UK, demonstrating that there are 2 to 3-fold increased risk of prostate cancer in men. Has a long-standing interest in cancer in general for his 22 years in chairmanship in the UK, registered patient charity, Cancer Black Care. He's been a government advisor on cancer since 2007. He co-chaired the Prostate Cancer Advisory Group and is a member of the Bowel Screening Advisory Committee. In 2013, he was awarded an MBE for services in the UK National Health Service in urology. Clinical interests include prostate cancer diagnostics, transperineal prostate biopsy to his institution, and prostate brachytherapy for prostate cancer. He's also a trustee of Tackle for prostate cancer and an advisor to the Prostate Cancer UK, and his website is here below. Welcome, Professor Frank Chinegwundoh.
Thank you very much. It's a pleasure to be here.
Awesome. Next up, we have Dr. Moraf Akchar. Dr. Moraf Akchar was born in Aleppo, Syria, and migrated to the US in 2006 in order to do medical school. He obtained his PhD in education from Indiana University, and currently he's practicing as a family physician and is associate professor at the University of Washington. In 2016, he was diagnosed with stage 4 lung cancer. Since then, his research has focused on experiences of patients living with lung cancer and on racial disparity. Welcome, Dr. Akchar.
Thank you all. It's an honor to be here.
Pleasant. And lastly, we have Pastor Ervell Bailey. Pastor Ervell Bailey is the lead pastor of New Day Christian Center. He received his certificate in Christian Studies between the years of 1999 to 2000 and received his ministerial license in 2008. He has evangelized throughout the UK, the US, South America, Africa, and Jamaica as he pursues his ambition to see lives transformed from the gospel of Jesus Christ, impacting the soul, spirit, and body. Welcome, Pastor Bailey.
Thank you. Welcome, everyone. Thank you.
Awesome, everyone. And to make sure, let's make sure we spotlight particular people. There we go. And where are you? Awesome. Glad we could spotlight all of you. Now, let's get into these questions, shall we? First things first, because all of you have a particular perspective when it comes to prostate cancer, or just cancer in general. I ask this as a very broad, open question for you to answer it any way you like. What is prostate cancer when it comes to you? Because we have a urological consultant, because we have a family physician, and because we have a survivor, it's interesting. We want to hear particulars when it comes to this particular thing. And I'll leave any one of you to start off.
If I can just start, I was diagnosed in 2017 towards the end of 2016, actually, with prostate cancer. I was given a diagnosis of, they used a Gleason score, which I'm still trying to figure out what it is. So maybe I can get some plain speaking on that. But I was given a Gleason score of 4+4, 4+3. I was told that I had a advanced high-grade tumor extending into the seminal vesicles, stage T3A and T3B. I was told that almost certainly the way to go was to have a prostatectomy rather than go for radiation or chemotherapy. And so that's the option that I went for, a prostatectomy under the Royal Marsden. I was told it was a stage 3. It was quite a shock to me. It really was quite a shock to me and my family. But I knew that I was in a situation where I needed treatment quite urgently. What it is something that affects you, of course, physically, but also psychologically, and to a degree spiritually as well. But certainly on a physical level, it affected obviously it affected me physically, I will say, in my ability to continue as men that we have been doing for many years. But it was something that I knew I needed to have treatment for. It's quite a difficult question to answer in terms of what it is, I'm finding. But hopefully I can get some clarity through this discussion as to exactly what it is. But I knew that my prostate was in serious trouble, and that if I didn't do anything about it, it was going to spread into my lymph nodes, and from there, it was going to be a lot more difficult for me.
Thank you for sharing, Pastor Bailey, especially since in terms of where you're coming from, a lot of it is the push towards treatment in order to avoid what you just said was getting into the lymph nodes when it comes to you. Dr. Akchar or Professor Chinegwundoh, you can chime in terms of this, being that you're on the medical side of things. What's your take in terms of what prostate cancer is? Because you all operate, at least for Professor Chinegwundoh and even Dr. Akchar, you might get patients that are in the beginning stages of understanding, do I have prostate cancer or do I not? And any one of you can answer.
Sure. Yeah, I mean, from my perspective as a urologist in secondary care, I would be referred men from their primary care physicians because of a suspicion of prostate cancer. Prostate cancer being where the cells of the prostate start to grow uncontrollably. And so most men would be referred because they've had this blood test called PSA, which stands for prostate specific antigen. And we encourage men to have this blood test every year because it acts as an early warning marker. So I would be referred men whose PSA was higher than it should be for their age. Then I would see the man, I would examine the man, I would do a rectal examination to feel the prostate, to feel its consistency. And then I would then say, well, your PSA is raised, maybe your prostate gland feels abnormal, there is a suspicion of prostate cancer. But to try and diagnose it, we would do an MRI scan, magnetic resonance imaging scan of the prostate gland, following which we would do a prostate biopsy, which means we'd put a needle into the prostate to take samples. And it's in a similar way, if a woman presents with a lump in the breast, the doctors will put a needle into the lump to try and get some tissue to make a diagnosis. So to make the diagnosis of prostate cancer, you've got to put a needle into the prostate, get some tissue, which is then analyzed in the lab. And then, and then we make the diagnosis of prostate cancer, and then take it from there. What happens next depends on how much there is in the prostate, depends on this Gleason score that my colleague has raised. So I would see it from, when already there's a suspicion from primary care. And the other thing that comes up quite often is that I will often see a man who says, I'm perfectly fine, I have no symptoms. I have no problems with urination, because many people know that, if you have problems with your prostate, you may get problems with passing urine, you may get problems with it being slow, you may go frequently, and so on. But what a lot of men don't realize is that you can have prostate cancer without having any urinary symptoms. So at times I'll see a man who's been referred because his PSA, which is done routinely, was higher than it should be. And the man is reluctant to undergo investigation because he feels perfectly well. So I have to impart that message. You may feel well, and that's great. I'm glad you feel well. It doesn't mean that you don't have prostate cancer. Thank you.
A wonderful overview at least in terms of the process of even detecting it and even going towards treatment, at least getting a consultant opinion. Dr. Akchar, do you have anything to add? Or?
Yeah, so for me, for engagement with the topic, it has to do with the conversations that I have with patients during their annual visits. In the United States, patients come to the doctors about once a year to do, we call it wellness visit or annual physical. And during those times, I often have conversations with men, if they are of a particular age, to talk about prostate cancer and getting screening with the PSA, as Dr. Chinegwundoh mentioned. So in the United States, the mood around getting those screening has been shifting, has shifted quite a bit, actually. Currently, if the person between the age of 55 and 69, male, of course, we're talking here, they are offered the screening. If they are considered of a higher risk, some groups like American Cancer Society would recommend also offering those screening at an even earlier age of 40. If a person is a Black male or if have family history, especially of early prostate cancer, then offered the screening test even before that. So as a family physician, as a general practitioner, I talk to patients about the tests. I tell them what it is a blood test, and I tell them about what could happen after. So because it is not a perfect test, it could be elevated because of other reasons. For example, if the prostate is itself larger, and we know that the prostate gets larger with age, then the numbers could be elevated. We call them false positive in a sense, elevated, but has not to do with cancer, but with a benign condition. So I explain to them what they could expect from this test, and the next steps. If it is elevated, going to send you to the urologist so they can do further investigations, as Dr. Chinegwundoh explained, with a biopsy and others. So that's one part of the conversations that I have with my patients. Again about screening. Screening is person comes with no symptoms, but we talk about doing tests so we can detect, we can find a disease before it starts to present itself. And unfortunately, with prostate cancer, the symptoms are non-specific, and often the patient doesn't come with symptoms. As Dr. Chinegwundoh explained, the disease is diagnosed and is silent in a sense. It doesn't present until at later stages. And I do get some patients with symptoms of prostate cancer, sometimes, again, similar related to urination, difficulty with urination, and sometimes blood in the urine or blood in the semen. So they come to me, and in that case, I do the digital rectal exam. I examine the person, detect check the prostate and see what's if I can feel a nodule or any irregularity, and then I do the PSA test. If I find a nodule, or if the PSA test is elevated, then I send them to the urologist. That's my experience with screening for the prostate cancer, with diagnosing. Once the disease is diagnosed, then continuing the journey with the patients. I am a cancer patient myself, so I know how. Thank you, Dr. Bailey, for sharing about your experiences. I understand how it's a life-changing experience to get a diagnosis of cancer, with all the uncertainty that opens and all the questions that come to the person, especially with speaking. Now the person has to learn a language that they didn't speak in a very medical context that's completely different and strange, foreign to that person. And then going through the questions about what's going to come, what's next, how long I will live, what's my life going to be like, what's the quality of my life. All those questions, a primary care provider, a family physician, or general practitioner can continue to have a conversation with the patient. Of course, the expert here is the urologist, is the cancer specialist, but a general practitioner can continue to provide support for the person throughout the journey.
3 different perspectives, and a lot of it hits close to home, especially physically and especially mentally, and even mentally engaging. Dr. Akchar, you actually brought up a great point in terms of discussing age when you get screened, especially within the U.S. And I received a question recently, and this might be more so to Professor Chinegwundoh, or even to Dr. or Pastor Bailey. Is the screening age different over in the UK? Like, I know in terms of breast cancer, it's different, but it's interesting to see if there's a difference in the UK. For us, it's 55 to 69. And as Dr. Akchar said, being Black, people will push you to get screened when you're 40. So I leave that question to you all.
Yeah, well, I mean, we don't, in the UK, we don't have routine screening. I disagree strongly with that, and that's a battle I've been having with the Department of Health and continue to have over many years. Having said that, what the government says that if you're a man at age 50 and you wish to have a PSA blood test, if you're age 50, you wish to know about the risk of prostate cancer, then you need to have a discussion with your primary care physician, and then they should do your PSA. Okay. Now, if you're at higher risk, i.e., you're Black, or you have a family history of prostate cancer, then you're allowed to have it on the National Health Service from the age of 45. Okay. So although there's no national screening, and although routinely we don't have men going once a year to their primary care physician, if you as a man are aware of PSA, then from 50 you can have it, or 45 if you're high risk.
I don't know if you can see the chat, but literally people are just like, there's no routine screening in the UK at all. That's mind-boggling.
It's shocking. I've been battling this for the last 20 years.
My goodness. And with that, I think, like, addition to what you said in terms of age of screen, thanks to Dr. Akchar and Professor Chinegwundoh, you brought up a good point. Even your family history plays a role, especially since there's different types of prostate cancer. Could either one of you, even Pastor Bailey, bring in terms of how family history even plays a role in regards to detecting or even going forth and consulting for prostate cancer? Because some people may not know their family history, but some people do, and they might feel fine, as you already said, but it might be something you should look at the horizon. Because in terms of prevention, there's a lot you can do to prevent, but really it's the point of risk reduction at this point. So can you give light to?
Yeah, I think that's a good point. In terms of family history, my dad had prostate cancer. My dad had prostate cancer. It wasn't aggressive prostate cancer as they would call it. But he had prostate cancer for which he was receiving some. It's interesting with my dad because we actually found out he didn't share it. He didn't actually share that that's what he had. We actually found out, such as some of the attitudes of some members of that generation. Everything was pretty much kept in-house. But anyhow, he was receiving some injections. And he did recover from prostate cancer, but he succumbed to another form of cancer. He ended up with bone cancer, which he succumbed to, and so that's played a part in my psyche, I guess, when I was diagnosed with prostate cancer. Is that does that open me up to other forms of cancer in a more, in terms of percentage wise than otherwise, if I didn't have cancer in the first place. So there is that, but definitely family history plays a part for sure.
If I could just comment on that, Pastor, in terms of the bone, prostate cancer, when it spreads, it's generally spreads to the bone. So, you know, two things strike me about your father's what happened with your father, in that, you know, if he was on the injections, normally we use the injections for prostate cancer when it has spread, you know, to the bones or to lymph glands. But at some point, those drugs become ineffective, and there may be other drugs tried, but ultimately that, you know, would lead to the man's demise. So it strikes me that if he had prostate cancer, and you're saying that he died because it spread to the bones, I think it's very unlikely that would have been a separate thing. I think that would have been the prostate cancer that had spread to his bones.
Wow. That's definitely interesting to me, Doctor, because that's not what was on his his death certificate. So I'll be interested to certainly look further into that, and maybe to talk more with you on that if that would be possible.
Yeah, but the thing is, and the point I make is that it doesn't mean that you're at a higher risk of getting another different cancer because you've had prostate cancer.
Right. Thanks for that.
A lot of engaging in terms of the chat, especially after what Pastor Bailey said and what Professor Chinegwundoh said. I'm interested to know, this is from a UK standpoint, Dr. Akchar, if you notice anything in the clinic, the general trends of seeing patients coming in, and even the consideration of family history. Because family history does a lot, but we also consider the other things such as, lifestyle and environmental factors that play a role in terms of our risk towards prostate cancer. So if you could speak to that.
Yeah, definitely. Some cancers do run in family, and we're identifying some genetic causes that had still continued probably for prostate and as well as for lung to be the rare condition, not the most common. There is an increased risk, and that is a recognized factor. So again, as I said, if you have, especially if there is a family history of a cancer diagnosis at an earlier stage, again, less than 65, then for prostate in the United States, that's considered a risk factor, and the person qualifies for earlier diagnosis, and that's a factor to be asked about and to be inquired for. There are other rare causes of rare cases of cancer that could be presented outside the prostate as well, and there's association with the prostate cancer. But again, those are more rare. And I would leave Dr. Chinegwundoh to Professor Chinegwundoh to comment on the science of the prostate cancer. He has probably more experience than I do.
No, the other thing that is worth saying at this point, if we're talking about family history, is that the female side is also important. So therefore, if you as a male has, maybe a mother or a sister or an aunt or someone on the female side has got either breast cancer or ovarian cancer, that increases your risk of getting prostate cancer. And in terms of the male side, if you have a first degree relative, say a father or a brother, your risk is doubled compared to maybe a friend of yours who doesn't have a family member with prostate cancer. If you've got two family members, maybe two brothers, or maybe a dad and a brother with prostate cancer, your risk is quadrupled. So certainly family history is important. It's important to know your family history, so as you can start, as my colleague said, get screened earlier.
It's interesting how, I guess, family history will run deep into this. A lot of the time when, at least we hear within school and how you look at family history, we focus on, I guess, our respective who received the actual cancer within our family line. Because I have friends that have had dads with prostate cancer and they're worried on that end. But I also know friends that had aunts and moms just having other cancers or other diseases that can also contribute. So if this is something that we've learned today, family history can run deep when it comes to your risk. Now, I believe Dr. Akchar brought this up, and either one of you can bring into light to this, but the prostate gland grows over time. Now, in terms of understanding that, I think one question that is on everyone's mind is okay, what's the purpose of it growing? Is it overdue to age? And is there a way you can halt or at least try to slow down its growth over time?
Well, I mean, it's a natural phenomenon that the prostate gland grows. You can't really stop it unless you were to do something very drastic and radical, such as remove your testicles, because prostate grows under the influence of testosterone. And so you can't stop it unless you castrate yourself, either physically or with medication. So we just have to accept that as you age, the prostate gland will grow. It will grow at different rates in different people. But the size of it is not really the main determinant. I mean, because it's big doesn't mean it's going to become cancerous. Because it's big doesn't mean that it's going to cause an obstruction or a blockage to the flow of your urine. So it's not such a big deal that the prostate gland gets bigger with age. It's more the effect that it has on your urination. That's the issue. So, you can have a prostate gland. So, for example, let's just give an example: 30 grams. A guy of maybe 40 to 50 prostate, if you were to take it out and weigh it, be about 30 grams in size. Okay, so you can have a man who's got a prostate gland of 300 grams. But because it's not compressing the water pipe, the urethra that runs through the middle of it, he doesn't have any symptoms. You can have a guy with a prostate gland of 20 grams, but because it happens to be tight around the urethra, he's got a lot of problems. So size isn't necessarily an indicator of how much trouble the prostate gland is going to cause you. And it's certainly not related to the risk of cancer.
It's interesting you say that, because now we're getting into, it's a whole gradient if you think about it, in terms of what you just said, in terms of you can have a 300 grams in terms of the prostate, but it's not constricting your urethra flow. Mm-hmm. But something that's 20 grams could do that, and everything quit, which is astonishing to me. I wonder, in terms of just, I guess, considering prostate cancer is just an enigma. Of course, you already said the prostate gland is a natural phenomenon. And of course, with prostate cancer, that phenomenon is extended miles out. What are some treatment plans that are available in terms of the UK? And maybe Dr. Akchar can speak to the US. We talked about this in the past panels in terms of that chemotherapy. Some people will see that chemotherapy is a must most of the time. And so it's interesting to hear what you would say treatment plan wise. If a prostate cancer patient will have to go that route, what is available to them? And could you explain what you have to do as a consultant, Professor Frank Chinegwundoh?
Well, I mean, I think if you mention the term chemotherapy, that would be a minority of men. And chemotherapy in prostate cancer, unlike other cancers, is used for late stage disease. it's not used for early prostate cancer. So the idea about prostate cancer is to detect it when it's confined to the prostate gland and not spread. So chemotherapy is used when it's late stage, when the cancer has already spread and you're trying to control it for a limited amount of time. It's definitely not first line. So in terms of first line treatments for prostate cancer, where there's no sign that it's spread beyond the confines of the prostate gland, you're talking about radical surgery, radical prostatectomy, such as the pastor had. You're talking about radiation treatment, whether by external radiation or internal radioactive seeds into the prostate gland. And then for a very select, and then also there's a concept of active surveillance. So active surveillance is where you just monitor, essentially you monitor the man because they've only got a low amount of prostate cancer. And if there's some signs that the prostate cancer is becoming more, then you can use your radical treatments before it's gotten out of hand. So those are, and more recently, there's a new concept, relatively new concept, which is called focal therapy. So the treatments I've mentioned before, such as radical surgery, external radiation, prostate brachytherapy, which is the seeds into the prostate gland, they treat the whole gland. Okay, but it's now possible to treat just parts of the gland where the cancer is and spare the rest of the gland to reduce the side effects of treatment. Yeah. Now, if the cancer has spread, then you're in a whole different ballgame. We can talk about that.
Yeah, and my intake on this, of course, I'm not the expert, and that's exactly where the PCP comes, or the primary doctor, the general practitioner comes to support, but from the outside. When the patient comes to me after they see the urologist, I meet with them and I say, hey, what did they explain to you? What are the options that were available for you? And my help as a general practitioner, and this is available for you, is sometimes clarifying some terms. I have a relationship that's been established for quite a long time with my patients. So after they go to visit a specialist for one time, sometimes the communication goes really well. Sometimes the person say, okay, they sat down, they explained to me everything, and I understand everything. At other times, we feel like, okay, well, they said this word, but I did not know what they meant. Can you add more context to it, or can you explain a little bit more to me? And that's my role here. My role is more as an interpreter, as opposed to a person who can give information, or I can give information as well as needed, but in the general sense, not to sway them one direction or the other. I can help them also with asking more questions to help them make the decision, but the decision in the end is made between them and the specialist, the urologist. And quite often, and I would let Dr. Chinegwundoh comment on that one, Professor Chinegwundoh, whether in some places there are tumor boards that were in complex cases that gets discussed, and of course more common cases, especially in earlier stages, the urologists themselves can make those decisions and put the treatment plan. So I would, again, in these spaces, the role of primary care becomes fairly limited to the support, to explaining, to continuing to help the person ask the right questions and get the information that they need, as opposed to directing the care and steering it one direction or the other.
If I can come in there, you rightly mentioned tumor boards. So in the UK, every single prostate cancer patient, in fact, every cancer patient is discussed at the appropriate tumor board. So that's been maybe the last 15 to 20 years. So before that, you could just have a urologist decide what treatment. But now every case has to be discussed. We call it MDT, multidisciplinary treatment, or multidisciplinary team. But it's the same as your tumor boards. So we have urologists, we have oncologists, we have pathologists, we have radiologists, we have nurse specialists.
To comment on that, in the U.S. context, this is not actually available everywhere. It doesn't have to be the case, even in cancer centers. The relationships often direct between the patient and their oncologist, who's often the sole provider. The tumor boards are available in certain contexts. One strategies that patients in the US compensate for that is to go to the expert oncologist as a second opinion. For example, often cancer centers would hire a person who's specialist in that particular kind of cancer that this person has. I'm speaking from a lung cancer perspective. There is this particular cause for this lung cancer, so you go to this particular specialist. I imagine, I don't know actually if this is the exact same case for prostate cancer, but I imagine there are some specialty and subspecialty. So in the United States, at times, patients seek that second opinion from the person they believe in cancer centers as the expert to then verify, validate, or give them the insight whether they're receiving the right treatment. This is not unproblematic, because at times you're going to get contradictory opinions, and then the person is left to decide, should I go with this opinion or that? But I think it is important to think about this as an option that's available, and to think, because again, you as a person, once I get diagnosed with cancer, at a sudden, like flip of a moment, I'm needing to make difficult decisions that may affect my life. So the trust in the specialist is very important. Finding the right team around you is very important. Allowing yourself to say, hey, can I seek another opinion? Can I get an insight from someone else, just to get a peace in the mind? I think that is okay for the person to have. And I'm speaking here as both as a physician. If I take care of someone, of course, I'm a primary care doctor, but I'm okay when the person says, I heard a contradictory opinion from another place. But of course, as a cancer patient, I sought another opinion. Tumor boards make this problem almost not exist, because the person is not operating by themselves, but they're getting the insights from other disciplines, and other discipline in the sense you're getting the oncologist, you're getting the surgeon, you're getting even the radiologist and the pathologist and others. And I imagine it's structured like that for interdisciplinary, as in people from multiple disciplines thinking together.
So there's an important difference. So everyone in the UK is treated at a cancer centre. So your diagnosis may be made in a district, what we call a district general hospital, a smaller hospital, but it's mandated that you go into a cancer centre. The cancer centres in the main are the big teaching university hospitals, where you have all the expertise. So that's kind of mandated. There's a set number of cancer hospitals, cancer centres, and where you'll get all the opinions. So and that's why everyone gets discussed at a tumor board, because everyone with cancer goes to a cancer centre. Yeah, and then another difference is, for example, I mean, you can do this because it's a national system, and it's a social. I guess it's a socialized system. The private sector isn't as advanced as it is in terms of numbers. Less than 10% of people would go into the private sector. So the vast majority are in the national health centre, and so there's sort of certain rules and regulations as to. So we don't have the same kind of shopping around, the same second opinions. It's far less common. It's far less common, because by definition you are going to the centre of excellence, and they'll be all over the country. Expertise is far and wide. And so one of the big differences I noticed from the States is, like, for example, if you need a radical prostatectomy, which is done using robotic technology nowadays. There's so many different centres, so many different hospitals can offer you that surgery. Whereas in the UK, these things are centralised. So in the whole of London, with 8-9 million people, there'll only be 4 major centres where you can go to have the radical prostatectomy. There may be 30 hospitals, but if your cancer is diagnosed at one of the smaller hospitals, they're not allowed to do your radical prostatectomy. You have to go to the cancer centre to have it done. Yeah.
Dr. Chinegwundoh and Moraf, Dr. Moraf and Pastor Ervell, can you please respond to some of the questions in the chat while we wait for Ralph to rejoin us?
I mean, what the professor was saying there. So in my case, I was under the Royal Marsden. So I was sent to the Royal Marsden in London, and which is as Professor said, is a cancer specialist hospital, and received my surgeon professor was a surgeon by the name of Dr. Cahill, Declan Cahill.
Declan, yes. I know him well.
You know him well, yeah.
I see him every week.
Okay, yeah. So I'm sure if you mention my name, he would remember. He took really good care of me. He put me onto a private wing of the hospital and gave me my own room and made sure I was taken care of, and my wife was taken care of as well. And I have nothing but praise for the way that I was treated. But if I could go back to when you mentioned about the size of the prostate and the effect that has, does the size of the prostate have an effect on the bladder at all? Does it?
It can
Can
do.
it? Okay.
It can do. Yeah.
So that may, if I know I'm speaking in layman's terms, but can it then affect the bladder in such a way that it then forces you to want to pass water more often than you would otherwise want to do in that sense?
Yes, it can, but it's more the fact that, you know, if the prostate is causing an obstruction, which that doesn't necessarily have to be a size thing, it can be a squeezing thing, then the bladder doesn't empty fully, so the bladder then has to go more often, trigger more often to try and get empty. So you develop what we call an overactive bladder, secondary to the obstruction.
Right.
Yeah.
Right. Because that was, I think that's one of the first things that I noticed personally, was that I had this feeling of having just passed water that I wanted to pass again. So that was one of the, I guess, symptoms that I noticed. And initially, I had what was called a flow test.
Yes.
So I had a flow test, and I had a very painful examination, which you would know, Professor, which was a what's the word? Cystoscopy.
Flexible cystoscopy, passing a camera down your urethra. Yes,
which I really hope I never go through that again. But that was, it was then decided that it was okay. But I still had this problem, and I think it was because obviously the prostate was affecting my bladder in some way.
Yeah.
And just a quick follow-up question on that, Pastor Bailey. But given all these challenges that the treatment is brought to you, what would you still say to men listening here regarding going forward for treatment?
That really is, because I started doing some work with Prostate Cancer UK, and I even had them come into my workplace, and I speak to men everywhere I go about this issue, and it never ceases to amaze me, you know, about the attitude that some of our men still have in regards to prostate cancer and being of a certain age. It's still something that's very much, you know, I had a friend of mine who died a year and a half ago, simply because he refused to have treatment. He just refused. He just buried his head in the sand. And there are some men I speak to who say, I'll do it when I'm this age, or I'll do it this. I feel fine. There's nothing wrong with me. And all of these kinds of things. And it's interesting because the day that I told my family, I have 4 brothers, and the day that I told my family, every single one of my brothers went and got a test. I'm not sure that they've had another test since, but certainly attitudes needs to change, and we need to keep getting the message out there about the importance of getting these things checked.
Yeah,
Absolutely.
I second that sentiment. I think one of the challenges with identifying cancers is that people who have fear of cancer, or who have symptoms that are suspicious of cancer, do not get the screening, or when, as they develop symptoms, they do not receive the care that they need. I speak here also not just as a family physician, but also as a cancer patient. I hear this sentiment quite often in the cancer community. A person would get the idea that this is a suspicious symptom and this could be cancer, but at times not wanting to deal with it. Because for varying reasons, actually, for a variety of reasons, and it's good to reflect on some of those. Some people continue to believe that cancers are not treatable. Once you get cancer, it's a death sentence. So if I'm going to die and die, what's the point to spend the last whatever months of my life just frantically dealing with this condition, and then going with chemo, going with this and that, if it's not going to change the outcome, I'm going to die anyway. And this is false. This is not true. There are tons of treatments for cancers, especially if they're diagnosed early. So this framework, this mindset actually can be self-defeating, because the person delays seeking care and thus presenting at later stages when there are less options for treatments available. Had this person who detected symptoms, let's say I'm speaking of lung cancer, or let's say prostate cancer, for example, started to have symptoms, was noticed blood in the urine, or blood in the semen, you could just brush it off or go to the doctor and tell about it. If the person brush it off and then a year or 2 later, then their cancers have progressed, could have been treated, or in a more benign interventions at an earlier stage. So that's really, really important. In certain spaces, in the US is a very big problem. In the UK also it can be an issue. Cost of treatment. Even in socialized medicine, taking off, if the person is doing jobs that bring them income, taking off to receive treatments also can be an issue. In the United States, it is that. Unfortunately, without socialized medicine in the United States, people, many do not have health insurance, so they show up in the emergency room when the disease is advanced. But again, the worry of the impact of the disease on the person's life make the person at times not seek the care at the time when there are symptoms. And we want, with those awareness-raising campaigns, to say, if you have symptoms, share that burden, share that stress with someone else. Share it with, that's what healthcare providers are for. You go to the doctor, does not mean you're going to get those investigations, but at least somebody who knows more about those conditions can help you make the decisions, can send you to the specialist. So you're having, instead of those thoughts just spinning in your own head, you're bouncing them with your primary care doctor, with a GP, or with a specialist, and you make more informed decision to optimize the condition, to get to the best condition possible. Yes, it might not change the outcome in certain cases, but that may not apply to you, actually. So why don't we get the information? Why don't we learn first as much as we can, and then get to making decision at a certain stage? So I'm glad that you're, Pastor Daly, I'm glad you're bringing this point about the worry about the illness and avoiding seeking the care.
We have Ralph now. Ralph, can you take it on from here?
I'm here. Hi, everybody. Someone just hit a poll knocked out all the electricity over here. So I'm dealing with my phone. But it seems like we had a lot of engagement in terms of all of this. I thank all of you, Dr. Chinegwundoh, Dr. Akchar, and Pastor Bailey. Before we wrap up, there are some questions that I'll just ask like maybe one or two, and then you all can put in the chat your information for reaching out to you all. I know Professor Chinegwundoh, you have your own website. Dr. Akchar, you can be reached somehow on Twitter. And then Pastor Bailey, I'm sure we can find your website as well. One of the big questions I think we've seen repeatedly in the chat is, what are the effects of getting a prostatectomy? You know, like getting it, of course, the benefits towards, in terms of going towards treating prostate cancer, but also what are the other effects out currently? Because, you know, side effects are always in everything.
Yeah, so I mean, you know, Pastor Bailey has got direct experience, but the things that we counsel men about are erectile issues, so erectile dysfunction, and that stops a lot of men wanting to have treatment. And I think there was a question about the role of women in supporting the men. One of the roles of the women is to reassure the man that she'd rather have him alive and in a relationship than have him dead. And so the support of the spouse is very important. So erectile dysfunction is a big one. Infertility is a second one, and urinary control problems, so urinary incontinence, that can be one of the side effects of radical surgery. So those are the things that we tend to worry about. Now, how likely is that to happen? There's so many factors determine the likelihood of that, of those things happening. Depends on the extent of the surgery, depends on the extent of your disease, depends, for example, whether you had good sexual function, before you got your prostate cancer. So, so there's a lot of counselling and that goes on before the man has surgery. So he's got some idea as to what may happen. Now, of course, not everyone gets side effects. So some people are very lucky. But we would always say these are the potential downsides of having surgery, for example. Now, even if you have radiation, there's certain potential side effects of radiation. So that can also have a negative impact on your ability to get any erections. It also dries up the seminal kind of discharge. You can have bladder problems. You can have kind of stool problems, as well, whether it's external or whether it's internal radiation. But for most of these things, there's something that can be done to kind of ease the side effects.
Yeah.
What can I add to this is often back to avoiding seeking care. Often those are seen as things that I would rather not live and just not get those symptoms or those experiences. And people would say those sentiments, and at times that can prevent the person from seeking the care. I would want to say that humans are resilient. I and Pastor Bailey have advanced conditions, but we live and we keep going and we keep fighting because we see things that are meaningful in life. And people become resilient to live despite and live with difficult conditions, because we learn how to manage our condition. We learn how to adjust. We learn how to cope. So the person often is making decision assuming that I won't be able to do it. I can't live like that. Well, actually, you can. Once you're there, and if you ask that person who's struggling with those, are you okay with doing this, or would you rather be not alive? And the person would say, I think I can manage this. Really can be terrible. This sucks, and it's good to recognize it's a struggle, but still, I'm glad that I have my family. I'm glad that I have the loved one. I'm glad that I continue to live in this society and contribute. So there are a lot of things that are there, and we want to bring the stories of people who have lived through this experience to then tell people that cancer is going to happen. 1 in 12 men is going to get prostate cancer, and if you're counting all the cancers together, probably more likely than not, the person's going to develop a cancer by the end of their lives. or general disease. So that's we need to remove the stigma. We need to let people know that people do continue to live and have meaningful life and adjust and cope even with advanced diseases. And of course, there are treatments, there are support, and when the conditions progress to being bad, I mean, this is life. We live, and everyone's going to die at some point, right? So, but we do, and we try, we optimize our condition until we can.
Yeah, I definitely agree with those points. I think as someone, as Doctor has said, initially, yeah, I felt like I felt kind of hopeless. I felt that my life was obviously going to change. I think post counselling is so important because there are some things that you are going to adjust to post surgery, and I was offered a great counselling service post surgery to help me to adjust to what life was going to look like moving forward for me. And I, obviously adjusting to what could be considered a new normal or new norm. So, and what was great was that the counselling was offered not just to myself, but it was offered to my wife as well. And we entered that together. And so that really made a difference. I definitely understood that I wasn't alone through the process, even though sometimes you may feel that way. One may feel that way. But there is an adjustment for myself. There's an adjustment for my children. There's an adjustment in the family as a whole, not just yourself. So I think to take advantage of which a lot of the trusts, a lot of the hospitals do offer post cancer treatment, and it's very important to make use of what's available. So I definitely concur with what's been said by the doctors.
Thank you, all three of you, for shedding. I think you shed a lot of light on terms of this particular disease, as well as the experience of it and what everyone can do. Thank you, Pastor Bailey. Thank you, Professor Chinegwundoh. And thank you, Dr. Akchar. And thank you for everyone in the audience for taking time to listen in on this conversation. The recording will be up soon for all of this, and I'm sure everyone will enjoy and be sure to share everywhere in order to get more information towards this disease as we go forth and manage it and be able to treat it better. Bye, everyone.